uremic toxins they deposit in the dermis, and then along with hyperphosphatemia, it can become very itchy. The patients can have like severe, they can have tremors when they have severe the BUN being very high. They can actually have inability to think straight, or very subtle changes in personality, disturbances in the sleep pattern. They can actually have a metallic taste in their mouth. That's actually very common. If you ask a patient with advanced kidney disease, ask them, do you have any metallic taste in your mouth? They'll say yes. They actually have nausea. When they're brushing their teeth in the morning, they feel like they're going to throw up. They have nausea, vomiting, but most of them, they have some degree of nausea. Particularly, we don't know why, but particularly the nausea in the uremic patient happens in the mornings, not in the afternoons or in the evenings. They can have a decreased appetite. They can have, let me think what else. They can have, when they have severe fluid retention, obviously we're confronted with like a patient with like severe kidney failure. They can have shortness of breath, they can have chest pain. But those are primarily the signs and symptoms with a patient with like end-stage kidney disease. But we're talking about nephrotic syndrome, and the only presentation of these patients is edema. And it can be very sudden onset. Like this guy was fine, and he gained how many pounds? I told you guys, like 20 pounds I wrote there. He gained like 20 pounds at the beginning of his accident. Yeah, that's a lot, right? That's very abnormal, especially if you gain 20 pounds in such a short period of time. All right, so keep going with the bullet points.
So, a swelling of patient-wide. The patient is informed of the diagnosis of nephrotic syndrome and the potential benefits and risks. Is that the same page with you?
I don't think so.
That's
the best lab test we do.
Oh, there we go. And swelling of the eyelids are frequently seen. This one?
Yeah.
Okay. So, what laboratory test would you order to confirm your diagnosis?
So, what do you guys want to order? There you go. Always. If you learn something from today, you always get a UA before you talk to your kidney attending. I'm telling you how many times I've gotten like presentations like, where's the UA? Like, oh, I haven't ordered one. Like, oh, thank you. Yeah, UA. So what do you expect to see? If this is purely nephrotic, we cover this. What do you expect to see? Just purely nephrotic. Protein, right? Yeah. That's it. And maybe you can see lipid casts. Maybe you can see Maltese cross if you do like if you're gonna get fancy. Mm-hmm. But like if you're just purely nephrotic, we see protein. And you may see ATN because some of these patients, they can present with acute tubular necrosis, and the reason being is nephrosarca, like edema of the nephrons that can compromise the circulation, and they can develop an ischemic injury of that nephron. But remember, ATN carries a good prognosis, like generally speaking. So it's always important to remember that. Okay, so.
Your analysis revealed 4+ proteinuria with a microscopic exam that revealed several waxy casts, oval fat bodies, no cellular casts, 1 red blood cell and 1 white blood cell per high-powered field.
Which is normal, right? 1 to 3 for both is normal. 1 to 3 RBCs or 1 to 3 WBCs. Mm-hmm.
Electrolytes included a BUN of 20 milligrams per deciliter, a creatinine of 1.3 milligrams per deciliter. Other electrolytes, glucose, calcium, and phosphorus were normal. A 24-hour urine collection showed 12 grams of protein and a creatinine clearance of 72 milliliters per minute. LFTs were normal, as was a prothrombin burn time. The patient's albumin was 1.9 grams per deciliter, and serum cholesterol was 670 milligrams per milliliter. Chest x-rays revealed bilateral pleural effusions without signs of pulmonary venous engorgement or abnormalities in the cardiac silhouette. Discussion points. Given the above information, what is the diagnosis of this patient?
We all concur nephrotic syndrome. So we need to give him a last name. I think that it's important that we give him a last name to that nephrotic syndrome. It's like if you come to me and you say, like, patient has a fever, like fever from what? So the same thing happens in nephrotic syndrome. I need to know what the cause is. So the question is, do we need to do a biopsy in this guy? And that's when your clinical judgment comes into play. You analyze the whole case. You have a guy who was completely healthy and a guy who got an injury and he got exposed to NSAIDs. So if I'm the attending on this case, I'm probably gonna wanna give it a try of like not taking any NSAIDs, bring him back in a couple of weeks, and I would expect that he starts having like improvement in that proteinuria. But when they don't improve, I think it's judgment. Like some nephrologists, they jump immediately and say, 12 grams? Wow, no, this guy needs a biopsy. I don't think there's any wrongdoing, but it's just like different styles. Like in my case, if he gives me a history, like I was taking ibuprofen like candy just to help my back pain, I would just say, you know what, just come back in a couple of weeks or 3 weeks, and let's reassess and don't take any NSAIDs. But let's keep going and see what I wrote there.
Construct and differential diagnosis of causes of nephrotic syndrome.
Okay.
What diagnostic studies would you send off looking for systemic diseases as a cause of nephrotic syndrome?
Okay.
What would your initial management of this patient be before the results of other tests became available?
Perfect. Let's stop there. So, construct a differential diagnosis for nephrotic syndrome. So, I want you guys, if possible, to mention one cause of nephrotic syndrome. We already said diabetes is the most common. What other minimal change? Somebody mentioned earlier minimal change disease. What else? What other types of nephrotic syndrome do you guys remember?
Membranous glomerulonephritis.
Membranous glomerulonephritis. Membranous can be primary or secondary. And we're going to cover the differential of membranous in a second. What other membranous syndromes do you guys remember? Fsgs, very good. Fsgs is growing. It's actually gaining a lot of like diagnoses in the U.S., primarily associated with the obesity epidemics that we have. And there is a theory about FSGS is common in the obese patient, but it's also common in the bodybuilders, because it looks like the kidney is exposed to a hyperfiltration injury, and that the typical FSGS lesion, which is a focal segmental sclerosis of the glomeruli, develops in these patients that for whatever reason they have hyperfiltration. Another example is the preemie babies. They have a higher risk of developing secondary FSGS down the line. And also we have those patients that are suffering from reflux nephropathy. Have you guys done the PEDS rotation? So these kids that they present with like unexplained boys with unexplained UTIs. Most of them, they have reflux, ureteral reflux, and down the road, those patients, they end up developing FSGS. But FSGS is becoming pretty popular in the renal biopsy registries in the United States because of the obesity primarily. Okay, what else? What other nephrotic? Yeah.
Because minimal doesn't FSGS.
No, they're different. One type of minimal can resemble FSGS, but in the pure definition, they're two distinct entities. So we have minimal change, we have FSGS, we have membranous. What else? Diabetes.
And the third one you're thinking is lupus?
Lupus can give you membranous. Lupus can give you nephrotic or nephritic. Remember the World Health Organization classification for lupus nephritis. They divide up lupus in 6 different histopathologic stages. It's complicated, but just roughly, the most aggressive ones are the type 3 and 4 and 6. I'm sorry. Yeah, type 3 and 4 and 5. The 6 is actually the kidney's gone. So it's called the type 4. The type 3 is called focal proliferative glomerulonephritis. Type 4 is called diffuse proliferative glomerulonephritis. It's a nephritic type of injury. It's very aggressive. And type 5 is membranous, secondary membranous to lupus. And the type 6 is diffuse sclerosing glomerulonephritis, meaning that the kidney has been replaced by interstitial fibrosis and tubular atrophy. So it's no good. When you get a report, renal biopsy report says type 6, you mean those kidneys are gone, pretty much. Remember, the kidney, once the kidney is damaged, it's replaced by scar tissue. So when I get a biopsy, that's another thing that I forgot to tell you guys. Doing a biopsy is also important, not just necessarily to establish diagnosis, but to establish the prognosis, because I get very important prognostic information. When I see active inflammation or active crescents, and the pathologist tells me there's really not much fibrosis or atrophy, I know that this is fresh. I know that I still have a good shot to be able to put the disease in remission and help the patient. But if I get a report with the same creatinine value, and the report is telling me that the patient already has 50% interstitial fibrosis and tubular atrophy, those kidneys are gone. So sometimes you have to make decisions based on what's best for the patients. Because if I have a patient, I tell them, I'm going to hit you, let's say that you come to my office with a creatinine of 2.8, and I know the biopsy is reading 50% atrophy. Why would I hit you with these immunosuppressive medications? And these medications are, they can harm people. You know, it's like a risk benefit. They can cause infection, they can cause malignancy, they can cause all sorts of like bad things. So that's another important thing that I forgot to mention when we were discussing the biopsy. It gives me a lot of prognostic information. Okay, so then we have like other things when you were mentioning about membranous. So membranous is either primary or it used to be called idiopathic membranous. We no longer call it, or some textbooks they still call it idiopathic, but they shouldn't call it idiopathic because back in 2010 somebody was able to isolate the antibody responsible for the pathogenesis of this disease was related to a very pathogenic antibody called the anti-PLA2 phospholipase A2 antibody, and that antibody actually causes inflammation and effacement of the food processes and massive amounts of proteinuria loss. So that's what we call idiopathic membranous versus secondary membranous. And secondary membranous can be associated with drugs. You guys remember which drugs? We already said one, NSAIDs. But you can also get it from captopril, which is the old-fashioned ACE inhibitor that some doctors are still using in the US. You can get it from Plavix, you can get it from Ticlopidine, you can get it from old rheumatology drugs like gold and penicillamine that they used to use before to treat rheumatologic diseases. But you can also get secondary membranous from rheumatoid arthritis. You can get it from Hep B, and this is huge for your boards. Make sure that you know that Hep B can actually be associated with membranous, secondary membranous glomerulonephritis. Whereas hepatitis C is associated with what type of kidney disease? You guys remember? Kidney disease. Hep C is associated with Hep C. You wanna write this down because I'm sure you're gonna get this board. So Hep B is associated with two types of disease, two types of systemic diseases. One is called secondary membranous, and the other one is called polyarteritis nodosum. So those are like the microaneurysms. They may show you a picture of a kidney with a bunch of little aneurysms in the distal, like renal arteries. So you do not want to biopsy those patients because they bleed to death. So, but if they show you a clinical case with a patient with a membranous, with a patient with hepatitis B, and they give you a picture of a renal angiogram and you see a bunch of little aneurysms, that's polyarteritis nodosum. So the diagnosis is done with the renal angiogram, but it's more like I've never seen that in clinical practice, but they ask you that question on your boards. So, and the other disease, I already said it, is the secondary membranous. Whereas hepatitis C is associated with two types of kidney disease. One is called the membranoproliferative glomerulonephritis, MPGN, and the other one is more like a systemic disease that is actually can be very serious if you don't diagnose it and treat it aggressively. It's called Cryoglobulinemia. Have you guys heard about cryocrate? So cryoglobulinemia is a systemic disease. So these patients, they present with necrotic lesions in the skin, like black lesions in the skin. They can present with like infarcts on the digits. They can present with like severe renal failure. And sometimes these patients also benefit from plasmapheresis. So on your boards, make sure you know those two disease associations. And secondary membranous can also be seen in patients suffering from occult malignancies. In fact, as a nephrologist, I've been able to diagnose cancers before the other doctors had, based on the results of the renal biopsy. If a patient tells me they have secondary membranous, I need to look where this is coming from. So the most common malignancies associated with secondary membranous are solid organ malignancies like breast and stomach cancer. But there's another disease, systemic disease, that is associated with a GN, which is minimal change disease. If you see minimal change disease in an adult, you have to think about a systemic disease association. In the kids, it's the most common cause of nephrotic syndrome. You guys know that. And in the kids, we all know that it carries a very good prognosis because you just give them a little bit of steroids. You don't even need to biopsy the kids. When you're very sure or suspecting that this is membranous, you just basically, when you suspect that this is minimal changes is in a child, you just give them a little bit of prednisone and most of the time that takes care of it. But if you have an adult with minimal change disease, you're required to rule out what hematologic condition? Non-Hodgkin's lymphoma. So make sure you write that down because they may ask you that question. So these are systemic diseases associated with kidney manifestations. So non-Hodgkin's lymphoma is minimal change disease. Hepatitis C is membranous proliferative glomerulonephritis or cryoglobulinemia. For hepatitis B is membranous or polyarteritis nodosum. You got it? Okay, so going back to other causes of secondary membranous, we have parasitic diseases. We have hepatitis, parasitic diseases like malaria and syphilis can actually cause secondary membranous, and that's one of the reasons why when you have a patient with a lot of proteinuria, you send some markers. We're going to go over that in a minute because you can develop it from infectious syphilis. HIV is associated with Fsgs. I don't know if you guys have heard about HIV in the kidneys. So sometimes they develop a very aggressive form of Fsgs that is called collapsing Fsgs. Collapsing because the glomeruli, the whole architecture of the glomeruli collapses due to the severity of the kidney involvement. And those patients, they go from normal renal function to dialysis within months. It's a pretty ominous form of Fsgs. So that's basically it. For FSGS, they may ask you on the boards the other disease associations with FSGS. So we have heroin use, so make sure you remember that one. Heroin use can cause FSGS. Also reflux, nephropathy, also obesity, HIV. Those are primarily the 4th disease associations. For minimal change disease, we already talked about it. It's for kids, it's expected and it's relatively benign. For adults, you treat it the same way with the steroids, but you're kind of obligated to rule out non-Hodgkin's. One of my first patients when I finished my fellowship came in with minimal change disease on the biopsy, and the previous nephrologist had done a CT scan of the abdomen, and he had like some sort of like spleen mass. So I referred the patient to see a hematologist. The hematologist said, oh, they already worked it up and the biopsy was inconclusive and we don't think to work this up further. Okay, you say, fine, I'm just going to treat him with the steroids. The guy had like relapsing minimal change disease over and over. So one day, 2 years after I met him for the first time, he came to my office and he had a mass in his axilla. And I sent him immediately for a core biopsy, and he had non-Hodgkin's lymphoma. So I went back to the hematologist and I told him, like, listen, you guys told me you didn't need to work it out. So the lymphoma was already stage 4 because it was everywhere. But fortunately, these days we can treat even like let's say you have a large B-cell lymphoma stage 4, it is curable up to 60-70% of the times. But obviously, it's kind of like embarrassing to have this patient coming in and you thought about it and the other doctor blew you off. So just make sure you guys are at least know this disease association, so you don't, like, this is a tough business. Medicine is a tough business. We're all gonna make mistakes, but you're gonna be more solid, clinically solid, I'm speaking, if you know this chronic disease association, because that's what makes the difference between you as a clinician versus a person that's more like technical, more like prescribing, or more like knowing pathways. When you're a clinician, when you're a true clinician, you recognize patterns and you make disease association, you think outside the box. That's how I see it. Okay, so basically that's minimal change membranous. So we talked about, okay, and then the other ones are the small vessel vasculitis. You guys know, like, we covered them briefly. We already talked about Goodpasture syndrome. And then we already talked about the ANCA-associated vasculitis. On your boards, they may give you an example of a person with a mononeurotic multiplex. Have you guys heard about that? So if they give you a clinical scenario where the patient is actually developed like some sort of like hand neurological injury, like a drop hand or like a cubital, like a drop foot or a drop hand, or like, what is the name of the radial nerve injury? It has a name. Like a claw hand, right? So a patient with a like a isolated neurological involvement, there is a condition called, you may want to write it down so you can learn more about it. It's called mononeurotic multiplex. So if you have a patient with that on your boards, they're trying to lead you to think about a small vessel vasculitis. Miguel, that goes there. You want to give him the feathers? Like he brought you that. Okay. Tell him where you got him from.
You're real. They came from my uncle's.
Peacocks.
Peacock, wow.
Yeah.
Real American boy. How's it going? Nice to see you.
Did you show him your little thing in your shirt? Show it to him. He would love that.
Wow.
So anyway, just write it down so you can learn about it. Mononeurotic multiplex. It's they almost want to guide you through a small vessel vasculitis. So you see these in ANCA-associated vasculitis or all sorts of vasculitis, and that may be the only manifestation. So because these patients with vasculitis, they may present with synovitis or arthralgias, or they may just present with a nerve dysfunction, or they can present with a vasculitic rash. You guys know what the vasculitic rash looks like? It's called purpura, right? Say it again. Henoch-Schönlein. Oh, thanks for bringing that up. So Henoch-Schönlein is a more severe form of IgA nephropathy. So these patients, they present with a characteristic skin rash. They have less favorable prognosis than the average IgA nephropathy, but some of them can just have a pretty benign, like indolent course. But it's a type of vasculitis, and it's strongly associated with IgA nephropathy. But the patients with a vasculitic rash, they can just present with like palpable purpura. That's how they describe it on your vignette on the boards. And the patient had palpable purpura, or they may show you the following rash, and you can tell that it's something that is raised, and it looks like a purpuric rash. So make sure you identify that, because they're leading you to think about a vasculitis, a form of vasculitis. Okay, so basically, so going back to the RPGNs, remember that's probably the worst nightmare for a nephrologist. Is like Dr. Ben-Zur missing a main LAD lesion, discharging a patient with a main LAD lesion to the street. So that's the worst nightmare for us, is to discharge someone with the possibility of having an RPGN. So RPGN is just a name. The differential diagnosis for RPGN, I already mentioned one of them earlier, the crescentic IgA nephropathy, which is more the exception and not the rule. But we also have lupus causing rapidly progressive glomerulonephritis, particularly the type 4, or also known as diffuse proliferative glomerulonephritis. That's the World Health Organization classification for lupus nephritis. And we also have the ANCA-associated vasculitis. There's 3 of them. I already told you guys that we're moving away from names, like naming a disease after someone. We're moving in a new era where we're more like physiopathology or descriptive of the actual disease. And we also have the anti-GBM disease that we mentioned. And up to 20% of the patients with ANCA-associated RPGN, they can present with a concomitant anti-GBM. And that's the reason why you always do the, not only the biopsy, but you always do the markers. You always send an ANCA, and you always send an anti-GBM. And the management is different, because if you have anti-GBM, what do? Plasmapheresis, right? Don't get it wrong in the boards. So plasmapheresis is for anti-GBM, for TTP, and for sometimes for cryoglobulinemia. We talk about that. So just make sure you don't get it wrong on your boards. Okay, so the third point that you mentioned there was what kind of testing we do, right? Mm-hmm. So you guys remember what kind of serological testing we do for these patients when we're doing a workup? What kind of serologies we send?
Well, for antibodies, I guess, in case you want to check for antihistones or lupus.
Yeah, but remember, drug-induced lupus doesn't cause kidney involvement.
Okay.
That's an interesting feature from that disease. It just doesn't cause kidney involvement. But you're right. So you want to screen for lupus. So the screening test for lupus is ANA. Very good. It's very rare to have an ANA negative lupus. What else? Complement levels, right? Because lupus can be associated with hypocomplementemia, but also cryoglobulinemia can be associated with a very low C3 value, not C4 but C3. And also some of the other Hep C related diseases, Hep C related renal diseases, can also present with hypocomplementemia, like the membranous proliferative glomerulonephritis. What else? What other tests? So we're thinking about rheumatologic diseases, vasculitis. What else do you guys want to order? Rheumatoid arthritis. So rheumatoid arthritis is interesting because it doesn't necessarily cause kidney disease per se, but secondary membranous has been associated with, in case reports, has been associated with rheumatoid arthritis. But also, patients that are very inflamed, and I've seen this a couple of times in my career, patients that are very inflamed either because they have a chronic osteomyelitis or because they have a very severe inflammatory conditions, they can develop renal amyloidosis. And remember, renal amyloidosis can be either primary or secondary. And we forgot to mention it as part of the differential of nephrotic. Renal amyloidosis, these patients present with severe proteinuria. This gentleman that I gave you guys the example has 12 grams. I've seen patients with 35, 40. One time I got a patient with 52 grams of protein. The guy's albumin was like 0.6. You can possibly imagine like all the complications. This guy was always in the hospital with refractory edema. His volume status was very tenuous and it was very difficult. I had him on 3 diuretics. He was on a thiazide, like I'm sure Dr. Ben-Zur uses metolazone here. He was on metolazone, he was on spironolactone, he was on Lasix. And the guy, despite that, he was going into like really bad edema from the severe nephrotic syndrome that he had. So renal amyloidosis, when you're confronted with big kidneys, like if they show you, by the way, what is the normal size of a human kidney? You guys remember? More or less? So it's anywhere, it's bigger in males. Well, the taller you are, the bigger the kidney. But it's expected to be anywhere from 10 to 12 centimeters. So that's the normal size of a kidney. There's no textbook definition of like what is normal and what is abnormal, but you have to just look at your patient. And if you have a very tall person and it gives you a 13 centimeter kidney, you don't worry about that. But if you have an enlarged kidney, you think about few entities. One of them is early diabetic nephropathy. Remember that there is this hyperfiltration phase. So if you have big kidneys in a diabetic, you can pretty confidently say that this person is in the early hypertrophy, and that's not good because the other stuff are to follow. But you can also see that in amyloidosis. So if you suspect that the patient has amyloidosis because for whatever reason, you do not want to biopsy the kidney because the amyloid is very vascularized and very high risk for bleeding. So there are other places where you can actually refer your patient and get a diagnosis. You can refer the patient to a general surgeon and they do a fat pad biopsy, or they do an oral mucosa biopsy, and that's a lot safer than doing a renal biopsy. For instance, another clinical scenario, I was just telling you guys earlier that you don't always biopsy the kidneys. If you suspect that somebody has like granulomatous with polyangiitis and the patient is not a candidate for renal biopsy for whatever reason, you can refer the patient to an ENT surgeon and they can do like a sinus biopsy. And you can see the same findings in the sinus biopsy, granuloma formation. So that's another way of be kind to your patients, because if they're not ready for a biopsy, you send them, you may have a bad outcome. Okay, so I already told you 2 conditions: early diabetic nephropathy, renal amyloidosis, lymphoma of the kidney. Actually, the kidney looks pretty big and it's all infiltrated by lymphocytes. So it's rare, but I've seen it once. Lymphoma. So those are primarily the three conditions that are associated with enlarged kidneys, like 14, 15 centimeters kidneys. And the other cause of like big kidneys is polycystic kidneys, but we all know that it's very different entity and very easy to diagnose it in a renal ultrasonography because the cysts are pretty distinct. Okay, so all right, so going back to the RPGNs, I already mentioned crescentic IgA, we already mentioned lupus, we already mentioned the small vessel vasculitis, we already mentioned the anti-GBM. And then again, it's all about the urine sediment. If you have a patient coming in with a normal urine sediment, it's impossible that you're having an RPGN. Just that simple. If you look at the urine sediment is completely clear, bland, and then abnormal creatinine, you're probably dealing with ATN, or you're probably dealing with some other form of kidney disease, but you're unlikely to have a nephritic syndrome. Yeah. But the urine sediment teaching point today is the urine sediment it gives us very valuable information. You should always get a UA when you're working up your patients. I think that's the main thing. Let's see, go ahead with the next point.
Yep. So laboratory tests were sent for anti-nuclear antibodies, serum complements, and fasting blood sugar, which were all normal. A VDRL and hepatitis B and C serologies were also negative. Discussion point: would you recommend a kidney biopsy for this patient and why?
Mm-hmm.
The patient is informed of his diagnosis of Nephrotic Syndrome and the potential benefits and risk of a kidney biopsy and looking for the etiology of his problem. He consented and the procedure is done without complications. The results of the biopsy showed evidence of membranous glomerulonephritis. Discussion point: how common is membranous glomerulonephritis in adult patients with nephrotic syndrome?
Okay, so before we move on, what are the diseases that you need to rule out if you have membranous? Lupus, secondary membranous. Mm-hmm. What else? HIV is more Fsgs. Hepatitis B. Remember, don't get it wrong because you're going to get that one. Hep B can cause membranous. And I told you about solid organ malignancies. So the pathologist, the renal pathologist is going to tell you this looks like idiopathic, but I already told you we don't call it idiopathic because we already know what the physiopathology is. Versus secondary. If the pathologists say this is consistent with secondary membranous, they're able to tell based on some deposits that there are more commonly seen, like some basal deposits that are more commonly seen in secondary. If they mention the word secondary membranous, you're obligated to look for disease associations, like either this is a drug-induced secondary membranous, or this is a parasitic disease secondary membranous, or this is a viral disease secondary membranous, or this is basically a malignancy associated. It's more like, I don't see it as a paraneoplastic syndrome, but I've seen patients with, the first thing they present is proteinuria, and the next thing I know I recently had a patient, I sent them for an EGD and she had gastric cancer, early onset gastric cancer. And I got the referral because the patient came in with a lot of proteinuria. And then I was fortunate because the pathologist that I work with, he's very good. And he sent me a note telling me like suspect disease association because this biopsy is very consistent with secondary membranous. And sure enough, I told the lady, like, you shouldn't thank me, you should thank the pathologist because he's the one who did a great job, like pointing out that this was not just a typical membranous. When I was working at Oliveview, we had a very unfortunate case. A patient presented with membranous on the renal biopsy. The patient was an immigrant from some Central American country. The decision was to start treatment. You guys know how we treat membranous? By the way, you guys know? Okay, so there's 2 ways of treating. There's like 3 ways of treating membranous. Most patients, they get a little bit of prednisone. I'm talking about like you pulse them when they have a lot of when you have a lot of proteinuria, you pulse them with solumedrol, methylprednisolone, and then you give them a little bit of prednisone, like 10 milligrams every other day, in combination with calcineurin inhibitor called cyclosporine. Cyclosporine is the medication that we use for transplant prophylaxis, transplant rejection prophylaxis, but we also use it in a lot of these vasculitis and primary renal diseases. So the decision was to start treating this gentleman, and on probably like month 2, he became septic. He was very sick. He presented to the hospital with acute respiratory failure. He had like ARDS picture, like his lungs were completely like white out, and they took him in the ICU. They took him for diagnostic bronchoscopy. They did a lavage, and finally the patient expired. And about 3 weeks after, when they They were able to look at the slides and everything. The pulmonologist actually presented the case at the conference, at the monthly meeting. The patient actually had strongyloidiasis, disseminated strongyloidiasis. And he was able to isolate like the alveoli with the strongyloid. Actually, it was a beautiful picture, not for the patient, but it was a beautiful picture, educational speaking. And the strongyloid organism was right there in the alveoli. And the teaching point is that from now on, every time I have a patient with membranous, an immigrant patient, either from some Latin American country or from some Asian country, I always screen for TB because you are going to give him immunosuppression. So I always do a Quant Gold or a PPD. And I always investigate for strongyloidiasis because these diseases are quite prevalent, especially in the immigrants. So it was very unfortunate because I think looking the case back, everything could have been avoided had we thought about the possibility of this patient having secondary membranous to strongyloidiasis. And we missed the picture. We ended up treating him as primary and he didn't have primary. So that's why it's important that you read the pathology report. If they say it's primary, there is a test that now is available, clinically available. It's called the anti-PLA2, anti-phospholipase antibody 2. It's clinically available. If the test is positive and you have a renal biopsy suggestive of primary or idiopathic membranous, your probability of having primary membranous is pretty high. It's like 95%. They published that paper in the New England Journal. But if you're confronted with a secondary membranous, you may want to find out what's going on. There is a disease association that you want to find out. So speaking about primary membranous or idiopathic membranous, this disease has 3 types of behaviors, like clinical behaviors. A third of the patients can actually have a pretty benign course and the proteinuria can disappear. There is 1/3 of the patients that they will progress unless you treat them. And there is 1/3 of the patients that they will progress no matter what you do. Even if you treat them aggressively, if you give them Cytoxan, you give them monthly chemotherapy, they will end up on dialysis. So we make decisions based on the amount of protein. So if I were to classify this clinical case that we're reviewing, he just came to the clinic and we measured his proteinuria about 12 grams, I wrote, right? I said 12 grams? Yeah, so 12 grams, this patient has, if the 12 grams have been present for more than 6 months, by definition he's in the high risk for progression category, and this patient's treatment is clearly indicated for this patient. But like I was just telling you earlier, if the patient fell from his bike and he was taking a lot of NSAIDs, I may want to give him a try. There's nothing wrong by waiting a couple of weeks.
Yeah.
And then if the proteinuria is still there, I would definitely just go for it. But if it isn't, I would just basically, just start treating him. Okay? So basically that would be it. What else does it say there?
And then it just has a discussion points. So it goes, how common? So we talked about that. Can you determine the etiology of the patient's glomerulonephritis based on the biopsy? What are likely secondary causes of membranous glomerulonephritis in adults? Include the parasitic diseases, viral hepatitis, solid tumors, and certain drugs, including gold, penicillamine, and NSAIDs. What is the prognosis for this patient developing end-stage renal disease? Approximately 30% of patients experience complete remission of the disease without therapy. Other patients maintain a stable renal function of 15 years or more, while others rapidly progress into chronic renal failure.
Right.
Are there predictors regarding which course this patient will take? The heavy proteinuria for greater than 6 months often portends a poor diagnosis. How would you treat this patient? Use of corticosteroid and other immunosuppressive agents have been used in improving patients' initial outcomes. You covered all that stuff.
Yeah. So basically, that's how we approach these patients with proteinuria. The key point is that when we always hear about proteinuria, we always think about renal disease, but there's more and more research linking proteinuria, or at least what we call microalbuminuria. Have you guys heard about microalbuminuria in the primary care clinic? So they screen for proteinuria with a test called microalbumin over creatinine. So there was a change in practice, and I want you guys to be familiar because a lot of the textbooks, they still call it they still call it microalbuminuria, but we no longer call it microalbuminuria. We call it, if you have the ratio less than 30 is normal. Remember, microalbumin over creatinine. And the ratio anywhere from 30 to 300, we call it moderately elevated albuminuria. And anything greater than 300, we call it severely elevated albuminuria. So that's a change of classification. We used to call it like, oh, he has microalbuminuria. Now, this new classification intends to raise more awareness on the primary doctors to put these patients in a different category of risk. Because we know that having microalbuminuria is not necessarily a sign of kidney disease, but is more a sign of endothelial dysfunction. And a lot of the times, patients may not even have diabetes and they present with microalbuminuria. Those patients, they have a higher risk for cardiovascular disease. I already explained to you guys that my patients don't die from kidney-related complications. I actually have to convince them that they need dialysis because they all feel fine. If you have kidney disease, you're like 10 times more likely to develop heart disease. And that's the point that I want to emphasize to all of you guys. Like kidney disease patients, yes, we have a therapy available, which is dialysis. And more commonly, we're seeing transplantation as an option for our patients. But the key point is that when they look at epidemiological data, these patients, when they start progressing, like when they go from anywhere from stage 3 kidney disease to stage 4, the likelihood of developing a cardiac-related event, it's significantly higher. And it's even much higher once you become dialysis dependent. Just to give you a perspective how serious it is to become dialysis, if you're a diabetic and you end up going into dialysis, the risk of dying at 10 years is greater than 70% for the diabetic on dialysis. And this is actually data that you guys can go. There's a website if you wanna spend some time. It's actually very useful. I use it a lot of times to prepare my slides. It's called USRD.org, United States Renal Data System, USRDS.org. And they compile all the data for transplantation, dialysis, and kidney disease from North America, including Canada. And they publish it every year. And if you put mortality on dialysis, you'll be surprised. Because the mortality is pretty high. Like after 10 years, the patients just start dying. And they don't die related to the dialysis treatment. They die from, like we were discussing on Thursday, they die from cardiovascular complications. They die from plaque formation, for like calcium deposits. These patients, they have a very unfavorable calcium phosphorus ratio. They're always struggling with keeping a calcium phosphorus product, which is, generally speaking, is acceptable to have a calcium phosphorus product lower than 55. And you just do that by multiplying the phosphorus levels by the calcium. So if your dialysis patient has a product greater than 55, the risk is pretty high. The cardiovascular risk is pretty high. So that's why, proteinuria is a manifestation, not necessarily from kidney disease, but also from endothelial dysfunction. So when you do your primary care patients, if you have a patient with proteinuria, what are the recommendations? What are you going to do for them? How are you going to manage these patients?
If they have proteinuria?
Yeah, if they have, let's say, like 150. I told you that now we call it moderately elevated albuminuria. Less than 30, normal. 30 to 300, moderately elevated albuminuria. 300 and up, severely elevated albuminuria. So what do you do for these patients? How do you manage them? Yeah.
Hold on. You said something about
No.
prednisone. You said methylprednisone.
If you're dealing with a nephrotic syndrome, but if you have a patient, let's say this is unrelated to nephrotic syndrome. You have a patient going to your clinic, you're following this patient because this person has hypertension, and he comes to your clinic and you're measuring end organ damage by doing a microalbumin, and you notice that the microalbumin is 150. What do you do for this patient?
Diuretics because of proteinuria and
What medication is first line for this patient?
statin.
Remember we talked about it on Thursday? So you have to have a very, very strong reason not to give it to him. ACE inhibitors, right? Always. ACE or ARB, whatever your preference, but never both. And what else do you tell your patient? You educate the patient that the risk category is much higher because of them having proteinuria. That puts them at a higher risk for cardiovascular events. So you have more aggressive lipid goals. You may want to give them an aspirin if indicated. And you're going to definitely advise the patient to do lifestyle modifications. Remember, that's on your boards. They're going to trick you. They're going to want to trick you for you to answer medications where, for every patient coming to the clinic, you may want to always try lifestyle modifications or like cessation of one of the medications associated with hypertension, like we discussed, NSAIDs, OCPs, and things like that. But you always want to make the patient aware of the higher risk category by having proteinuria. So in other words, the teaching home, when you guys go home from this talk, having protein in the urine is not always indicative of kidney disease. Nowadays, microalbuminuria is more and more recognized as an independent risk factor for endothelial dysfunction and cardiovascular complications and inflammation. And we see proteinuria in patients with inflammation, like inflammatory disorders like rheumatoid arthritis or some sort of like PMR, polymyalgia rheumatica. These patients, that's actually one of the differentials for proteinuria. Like exercise, aggressive exercise can give you proteinuria, which is benign, is not harmful in any way. Inflammatory conditions, urinary tract infections, and glomerular and kidney disease. But not always when you see it is necessarily associated with kidney disease. That's what I'm trying to say. Okay? Very good. Any other questions? Do you guys have any?
I have a question.
Yes.
Kind of just go back. We were talking about the lab for rapidly progressive glomerular nephritis, and we were mentioning complement levels in ANA, and I was just wondering what else. It seems like all of these inflammatory markers, like would send rate and CRP, kind of be useful in that setting as well?
You can send them, but it just tells you that there is some systemic inflammatory process, but it wouldn't help you to guide therapy. But the must-have are the ANA, the complement levels, ANCA, and the anti-GVM. Those are the must. And ultimately, like I said, you may need a biopsy because that's how you're able to further guide therapy and make decisions. The biopsy gives you not only the diagnosis, but it gives you important prognostic information. Because if I have a patient coming in with a creatinine of 2.9, and I already know that that kidney has been replaced by interstitial fibrosis and tubular atrophy, you know that this person is in trouble. You may want to have an open discussion with the patient to